The clinical application of X-rays was recognized within months of their discovery in 1896. Conventional radiograph suffers from two major limitations. First, it only shows 2 dimensions of a 3-dimensional object. Second, the X-ray information on film is very limited for diagnostic uses. This slide defines terms we will use during this presentation. Although we are showing you the most basic CT one-slice detector, the principles are the same, be it 1 slice, 256 slices, or 300. The information available is related to the reduction in X-ray beam intensity as it passes through the tissue. Individual photons in the beam may be scattered out of the beam or absorbed by the medium. In either case, the photon is removed from the beam, reducing its intensity. The degree by which the emergent beam intensity is diminished compared with the initial beam depends on a number of factors. The greater the distance through the tissue traversed by the beam, the more intensity reduction, or attenuation, takes place. The energy of the X-ray photons is also a factor in beam attenuation. In general, a higher energy beam will be attenuated less in passing through a given thickness of tissue than will a beam of lower intensity. The most important factor is the nature of the tissue itself. The effective atomic number of most body tissues is relatively low, and scattering represents the major factor in beam attenuation at diagnostic X-ray energies. Consequently, tissue of higher density will attenuate the X-ray beam to a greater degree than tissue of low density. This provides a basis for differentiating between tissues with X-rays. The ability of a particular material to attenuate an X-ray beam is characterized by its linear attenuation coefficient. The numerical value of mu with units of per centimeter represents the probability that a photon will be absorbed for each centimeter of tissue traversed. Each type of tissue has its own value for mu, but this value is also dependent on the energy of the X-ray. Consequently, linear attenuation coefficients are for a specific energy and will change as the X-ray beam energy changes. Since the relationship between beam attenuation, which is the linear attenuation coefficient of the tissue, and its thickness x is known, then by measuring the initial intensity I0 and the transmitted beam intensity I, it is possible to calculate mu. In this way, specific information on the nature of the tissue can be obtained. When the X-ray beam is passed through the human body, it traverses a number of different tissues, each with its own characteristic linear attenuation coefficient. With only one set of measurements of I0 and I, it is possible to calculate a linear attenuation coefficient, which represents an average of all the tissues in the beam. However, it is not possible to reconstruct the mu values for each type of tissue. It's not difficult to visualize a situation in conventional radiography where the X-ray beam traverses 2 different tissue pathways. In this case, the transmitted intensity is recorded on X-ray film. It's quite conceivable that although the tissue pathways differ markedly, the total attenuation of the beam could be the same, so that the film exposure will also be the same. It's not possible for the physician interpreting the film to mentally reconstruct the various types of tissue along the beam path. Before more specific information can be gained about different tissue attenuation coefficients, it's necessary to gather more data. In this situation involving 4 different types of tissue, 2 individual X-ray transmission measurements, I1 and I2, can be made. By rotating the X-ray beam, 2 additional unique transmission measurements, I3 and I4, can be made, increasing the available date. It's interesting to note, however, that even in this relatively simple situation, 4 transmission measurements are not sufficient to permit a unique calculation or a reconstruction of the object. For example, these 2 combinations of the same tissues will each produce identical values for the 4 X-ray transmission measurements. Additional measurements are needed if the right combination is to be specified. 2 more transmission measurements taken diagonally provide sufficient information for an accurate reconstruction in this case. It's important to recognize that the accuracy of reconstruction is fundamentally related to the number of X-ray transmission measurements. Since each of the 6 transmission measurements in the above example involves a unique combination of attenuation coefficient, it is possible to describe each one by the 4 mu values and their relative positions. If you consider that a single patient view utilizing this technique may involve more than 300,000 individual transmission measurements, the need for rapid and sophisticated data processing can be appreciated. A computer is essential if the reconstruction of mu values is to be accomplished in a reasonable time. While the reconstruction technique suggested by the 6 equations has been used, it has been generally replaced by faster methods. A technique known as back projection was developed in the early 1960s in conjunction with radionuclide brain scans. In this example, the X-ray tube traverses across the field to be scanned, and the detector signal represents a profile of the transmitted beam intensity. Since the discontinuity from the central object can only be localized in one dimension by a single scan, it is back projected across the entire field. A series of back projected profiles of the same field are generated rotating the X-ray tube after each traverse. After a sufficient number of single scans or views are accumulated, they can be superimposed to reconstruct the original field. While the back projections of the central object to reinforce in the correct position, a characteristic star pattern is also present. This results from the attenuation data projected outside of the object by the reconstruction technique. Increasing the number of views reduces the visibility of these star artifacts, but there's still a high background of erroneous data. A modification of this technique modified the detector signal so that the profile from a single object will have both positive and negative components. This filtered profile is then back projected to form a single scan field. Again, multiple views of the object. For each generation, a filtered back projection scan must be obtained. Combining all of these filtered back projections provides a much more accurate reconstruction of the original object. The effect of the arbitrary filter is to cancel out erroneous data. The way in which multiple views of the patient from different angles are generated has been approached several different ways. All, however, involve moving the X-ray source about the patient. Following reconstruction, the patient slice is represented by a series of numbers, each one representing the tissue attenuation coefficient for a small volume of patient. In this slide of the CT numbers representing an axial slice through the head, the position of the skull can be seen because of the higher numbers associated with the relatively dense bone. However, in most cases, it is preferable to have an image of the patient slice for interpretation rather than the basic quantitative data. This is readily achieved by assigning each CT number a shade of gray. In this way, an image very comparable to an X-ray can be generated. A major difference, however, is that the original data remains in the computer, and the way in which it is displayed can be controlled by the physician, so that the maximum diagnostic information is retrieved. The area of the patient characterized by a CT number is referred to as picture, element, or pixel. The amount of detail available on a patient image is related to the size of the pixel in the reconstruction matrix. Very large pixels, each with a single gray shade representing the average attenuation over that area, will not display the fine detail in the object scanned. The abnormality depicted here might not be recognized because it is averaged in with the normal tissue in the rest of the pixel. Reducing the pixel size and increasing the extent of the reconstruction matrix will ensure that this abnormality can be detected. However, an even finer matrix is required if the exact shape of the lesion and its internal structure are to be recognized in the display. While the pixel size is obviously an important factor in determining the spatial resolution of the image, it must be remembered that there has to be an adequate number of transmission measurements in each view to provide the basic information. If the original data is insufficient, computer reconstruction of the image into very small pixel sizes will not increase the diagnostic information.